Hi, my name is John Weymouth. Thank you for attending this program on the anatomy and physiology of the eye. We're going to go through some basics about the eye and how this eye is related to the machines that you're learning how to use. So without any further ado, let's get started. The objectives of this particular program are to describe the chambers of the eye to you, identify structures related to vision and cataracts, describe the basic function of each of these structures, and describe the path of light through the eye. This is a picture of the eye, and starting in the upper left-hand corner, we have the sclera, choroid, iris, lens, pupil, cornea, aqueous, and vitreous body. And then on the right side, retina, fovea, optic disc, which is your blind spot, and your optic nerve. So you can see the eye is made up of more than just one structure, and a lot of times they take the eye and relate it to a camera, where the left-hand side would be the cornea, where you have the outside of the lens, and then you have an internal lens that actually focuses. So that little lens that you see in the center actually changes shape, and then that's projected back onto the retina. And the retina is like the photographic film in the eye. It converts those light rays to electronic impulses. They get collected and then get sent down the optic nerve to the brain, where the occipital lobe takes all this information and creates vision. So here is the eye. We're going to break it down into three major parts. We have the anterior chamber, posterior chamber, and the vitreous chamber. The anterior chamber is located between the cornea and the iris. The anterior chamber is filled with a clear fluid called aqueous humor, and the aqueous is produced by the ciliary body. The posterior chamber is a space between the iris and the vitreous chamber. It's filled with aqueous humor as well, and this is the part of the eye that contains the lens. So when a cataract develops, this is the area where the ophthalmologist focuses to remove the cataract. And finally, we have the vitreous chamber. This is the largest chamber in the eye, and it's filled with a thick matrix called vitreous humor. And the vitreous humor is kind of like the scaffolding. So when your eye is developing as an infant and you're growing in the womb, the vitreous forms, and then all the other layers grow and are developed around that scaffolding. So the vitreous is very important for the development of the eye, but from that point on, it only has one other purpose, and that's to make an ophthalmologist rich, because it gets into problems and they have to remove it. So there are machines out there that are designed to remove the vitreous, and that's like the ALCON Constellation system or the Stellaris unit from B&L. Those units are designed to be used by the retina surgeon to remove the vitreous. But for our cataract surgery, we don't typically worry about it. So now let's take a look at the eye and kind of zoom in on each of the different structures in detail. This is the cornea. It's the outermost surface of the eye, and it's the first part of the eye that refracts light. The cornea is made up of several layers. The outermost layer is called the cornea epithelium. This is the part that protects your eye from dust and germs, but it constantly regenerates. So if you were to scrape your eye and have an irritated eye, within hours those cells grow back. It's the outermost layer. It's about 5 layers to 6 layers thick, and it's the most regenerative part of the human body. The next layer is a very thin membrane, and it's called Bowman's membrane. And Bowman's membrane is just beneath the epithelium. It protects the cornea, and it's a barrier against microorganisms. It is a very, very tough membrane. So when a doctor does surgery and they're going in the eye, the blade will go very easily until it hits this membrane, and then they have to push through it. The next is the corneal stroma. It's the thickest layer of the eye. It's 90% of the cornea. The collagen fibrils run through and are parallel to each of other, and the parallel alignment gives the cornea its clarity. Next is Descemet's membrane. Descemet's membrane is a very thin, strong sheet, very similar to Bowman's membrane. It protects against disease and infection, and it's secreted by the endothelial cells. And finally, we have the corneal endothelium. This is the innermost part of the cornea. It helps keep the cornea transparent. What happens is that aqueous humor that's in the eye nourishes the cornea, so it actually leaks in past this layer of cells into the corneal stroma, but the more fluid you have in there, your cornea will get cloudy and white. So there's a special layer of cells on the endothelium that pump out the excess fluid so that the eye is roughly 40% hydrated. And if those cells get damaged, then what will happen, the stroma will swell up and with water, and you get a hazy, opaque looking cornea. And these endothelial cells do not regenerate. So once they are damaged or they die or fall off, the other cells that are still remaining expand to cover over that area where the cells are missing, so they get less efficient and they have to work a little bit harder in order to keep the cornea clear. If you lose those, you end up with blindness. So now we're going to talk about the iris and the pupil. The iris is a very thin structure. It controls the pupil diameter. There are muscles in there that react to light and adjust accordingly. There's a sphincter muscle which goes around the inner ring of the iris, and then there are radial ones like spokes to a wheel that go from the inner radial of the iris out to the edge, and those are the dilator muscles. So the sphincter will close the lens or the pupil down, and the dilator muscles will pull the pupil open. So for cataract surgery, it's important that those dilator muscles are fully contracted so that the pupil is as large as possible. So before surgery, they'll put drops in the eye, and these drops make the dilator muscles contract, hence giving you a nice large pupil. The pupil is a hole in the center of the iris. It functions like the aperture of a camera. So the smaller the pupil, on an f-stop, it would be like 22. If it opens up real wide, then you have a higher or lower number. The pupil must be fully dilated for cataract surgery. What we see here now is a representation of how the pupil reacts to light. As the light goes across the pupil and into the eye reacts through a feedback loop from the retina to the brain and back to the muscles in the iris, so that when it's bright, it actually closes down the pupil to restrict the amount of light getting into the eye, and that all happens automatically. Now we're going to focus in on the sclera, the white part of the eye. On top of the sclera, there is a thin membrane called the conjunctiva. So when somebody gets pink eye, it's actually the conjunctiva getting infected, and they call it conjunctivitis. The conjunctiva is a membrane that circumvents around the edge of the cornea. It goes over top of the sclera and folds back and now lines the underneath side of your eyelids. So there's no way something can get behind your eye. If you wear contacts and the contact disappears, it's basically caught in that fold. So you pull your eyelid up, you look down, and there's the lens. So nothing can go behind and get through that. It's very similar to if you had a gear shift on a truck or a pickup truck where your gear shift shaft goes down to the floor. There's this rubber boot that goes around it. That's designed to keep things from falling in there. Same thing with the conjunctiva. It seals so nothing can get in behind the eye. This is a cross-sectional view of what the eye looks like. So you can see the conjunctiva on the outside, and then you have your cornea, your iris, your lens. So it's a kind of nice little, gives you an idea of how the whole eye works as a system. And there's an area there called the trabecular meshwork. So when the ciliary body produces the aqueous humor, it flows in, it nourishes the lens, it floats through the anterior chamber, nourishes the cornea, pulling out, the waste material, because it just basically, it's a very rich nutrient fluid that keeps the cells happy, but then the cells excrete their waste products. And then the aqueous humor flows out of the eye through this area called the trabecular meshwork. And it's very similar to a drain that you would see on a street where the leaves collect. Well, in this particular situation, if that were to get blocked like a drain, then it would fill up the eye itself, and the eye would get pressurized, and the more pressurized it is, it squeezes blood out of the retina, and you end up with tunnel vision. So people who have glaucoma have too much aqueous being produced, and it's not being excreted or pushing through the trabecular meshwork like it should. So with that situation, you need to make sure that the trabecular meshwork is open. So they've done things like they make cuts in it. They will put this little particular picture here shows a bleb where they try to remove the pressure from inside the eye and try to get it outside. They'll use drugs. Drugs are designed to keep the aqueous humor from being produced as much. So there's a lot of ways to fix it, but bottom line, if the flow is not good, you end up with glaucoma. Now we're going to talk about the crystalline lens. This is the part of the eye that turns into the cataract. It's roughly the size of an aspirin tablet. It's the only structure in the body directly affected by aging. It grows opaque over time, and it's a normal part of aging. It dynamically focuses the light onto the retina, and it's contained within a bag-like structure called the capsule. This is a picture showing what it would look like from the doctor's point of view during surgery, where they have the phaco needle and a second instrument that helps them, and they're in the process of removing the lens material that is cataractus. During the latter part of the procedure, after they got the bulk of the lens material out, there's another instrument that they use that it pulls the fine remnants of the lens that are still in the eye, and it's called an INA handpiece, or irrigation aspiration. Next, we have what is called the crystalline lens support. The capsule in the eye is suspended by some very fine hair-like ligaments called zonules. These zonules are attached to the ciliary body, which is that area that produces the aqueous humor, but it's also a muscle. So the contraction of that ciliary body pulls on these zonules, and it reshapes the lens size. And this process is called accommodation. So when you get older and you're in your 40s or 50s and you can no longer really focus your lens, it's not like there's anything wrong with the ciliary body or the zonules. It's that your lens is now hard. So the zonules are being pulled on, the ciliary body's trying to focus, and it's just not happening. So in that situation, you end up, you're starting to form a cataract, or the lens is getting hard. And in that process, you have to start wearing, different types of glasses, because you can no longer focus your eye. And a good test to do is you can put your finger right up to your eye and look at it, and then remove your finger and look in the distance, and you'll notice that you can change your focus. When you get older, you bring your finger up to your eye, you can't even see it. It's totally out of focus. That's because you can't change your focus. And another thing that's interesting, when you are younger and you're driving in the fog, and you've been in the fog for maybe 15, 20 minutes, and after you finish driving, your eyes ache. That's because your lens in the brain were looking to focus on something, and there was nothing to focus on. So that ciliary body was constantly pulling and relaxing and pulling and relaxing on the lens, trying to focus on something. And as a result, it's like your eye doing a bunch of push-ups. Those muscles actually get sore, so your eye will ache. So that's what happens when you drive in the fog. So it's actually good exercise for your ciliary body. So these little structures called the zonules are in this picture here. We'll get a nice little high resolution photograph. You can see those very thin little strands. Those are the hair-like fibers called zonules that attach to the edge of the capsule of the lens. So the lens is actually floating and being supported, a lot like a trampoline would be. And this next picture here shows you an electron micrograph picture of the back side of the eye, where you can see the lens and all the zonules attached. So that concludes what the eye anatomy course is. And this is simply a picture of the operating room where they're doing, in this particular case, retina surgery. So you can see the instruments set up there and how the nurse and the doctor are in proximity to each other. And there's one thing wrong with this picture. With retina surgery, the lights are all off in the room, so you wouldn't be able to see anything. So this was taken just to give you an idea of what the operating room environment looks like.